Thank you for inviting me to share my experience of screening for Duchenne muscular dystrophy and to discuss some of the future challenges that we face in order to develop an appropriate screening protocol for this devastating condition. I'm the Director of Newborn Screening for Wales UK, and I was the former Director of the DMD screening programme for Wales, and that's why I've been invited here to actually discuss and share my experiences of screening for Duchenne muscular dystrophy, and also to elaborate further some of the future challenges that we face in order to develop an appropriate screening protocol for this devastating condition. So what is Duchenne muscular dystrophy? Duchenne is a fatal X-linked neuromuscular condition that is brought about by mutations in the dystrophin gene, which result in the absence of a protein called dystrophin. And dystrophin is required to maintain the structural integrity of muscle cell fibres. Duchenne has a worldwide incidence of around 1 in 5,000 males. However, female carriers may manifest clinically later on in life with proximal muscle weakness. The diagnosis is usually made by biochemical genetics and histology from a muscle biopsy. And the serum CK activities that we observe in these boys at diagnosis are usually 10 to 20 times the upper limit of the reference interval for CK in plasma or serum. The mean age of diagnosis is around 5 years of age, and the mean diagnostic odyssey is around 2 to 3 years. And the fact that what that means is the fact that it takes 2 to 3 years for a boy to actually be diagnosed once they've entered various investigations. However, the mean age of diagnosis has not changed for over 20 years, and this delay in diagnosis causes considerable parental anxiety and harms. Those boys with Duchenne present in early childhood with proximal muscle weakness, and boys with DMD will never be able to run properly, and they present around the ages of 3 to 5 with early signs of muscle weakness. They present with motor delay, toe walking, and they often appear to be clumsy and have frequent falls. By the ages of 6 to 10, they have progressive muscle weakness. They have a positive Gower signs, and that's whereby these boys are unable to get up from the sitting position with their arms folded. Their cognitive abilities are not usually affected. However, those boys that have severe dystrophin deletions can present with a global developmental delay. By the age of 12 and older, these boys are wheelchair dependent, and the disease eventually affects all the voluntary heart and respiratory muscles, and survival is very rare beyond the age of 30. Newborn screening for Duchenne is controversial, and there are established criteria for selecting those disorders which justify a screening program. And at the time when many of the Duchenne screening pilot programs were implemented, there was no treatment or cure for this condition. But it's important to remember that the Wilson and Jungner criteria on which screening policy is based were originally drafted with adult disease in mind, and therefore the family dimensions inherent in any newborn screening program, such as the importance that parents attach to an early diagnosis even though no effective treatment may be available, and the broader impact of childhood diseases on the family members. And the main arguments for newborn screening is the fact that it avoids diagnostic delay, it permits reproductive choices and allows planning of the care of the affected boy, such as adapting the home to allow access for a wheelchair. However, there are disadvantages, and the main disadvantages that is quoted is the fact that early pre-symptomatic diagnosis could affect family stability. It's long been recognised that CK activities are increased in asymptomatic boys with Duchenne. And the development of the bloodspot CK enzyme assays in the 1970s very much paved the way for newborn screening programmes. And in the last 40 years, there have been 17 programs in 10 different countries with approximately 1.8 million infants having been screened. However, at present, no country currently screens for this condition on a national basis. The Wales Newborn Screening Programme was the second longest programme in the world, but was probably the most comprehensive in terms of the follow-up and outcome data. The screening test was an opt-in test, and parents had to consent for their son to be tested. And the samples were screened using a bloodspot CK enzyme activity test. And the programme here in Wales ran for 21 years between 1990 and 2011. This slide shows the Wales DMD screening protocol, and here in Wales the bloodspot samples are collected on day 5 to 8 of life, and the samples are tested in singlet for CK. And those samples with a CK activity less than 200 units per litre was then reported as DMD not suspected. Those samples whereby there was a CK greater than 200 units per litre were then repeated in duplicate, and then the mean of the triplicates calculated. And if the mean of the triplicates calculated was less than 250, again, that sample would be reported as not suspected. However, if the mean of the triplicates was actually greater than 250, this boy would then be followed up around 6 to 8 weeks after the screening sample has been taken. And this 6 to 8 week period was set in place to allow the family to bond with their newborn son, and in the hope that this would prevent rejection of the child following a potential diagnosis. And they were followed up at the 6 to 8 week period using a serum CK activity. Now, if the serum CK activity was normal, again, this boy would be referred as DMD not suspected. However, if there was a raised serum CK identified, this boy would then be followed up with a suspected DMD diagnosis, and they would then undergo genetic and potentially a muscle biopsy to confirm that diagnosis. This slide shows the serum CK or plasma CK concentrations at the 6 to 8 week follow-up in infants with a screen-positive bloodspot CK. And what we can clearly see in this graph is the fact that the plasma CK activities in the genetically confirmed DMD cases clearly distinguishes those from the results obtained from the boys with a transiently raised CK. And what we see here are CK activities ranging from 2,500 up to 14,000, with a mean concentration around 8,000 versus a mean CK activity of 45 in the transient cases. During the 21-year period of screening, we screened just over 343,000 boys, and we identified 56 cases. And our protocol had a sensitivity of 80% and a positive predictive value of just under 40%. However, of significant concern was the fact that we identified 16 false negative cases. The programme was terminated in November 2011 due to issues around reagent sustainability and the withdrawal of the external quality assurance programme by the CDC in the US. The original aim of newborn screening programmes for Duchenne was to reduce the diagnostic delay and provide reproductive options. However, in the last few years, there has been renewed interest in screening for Duchenne, and this is due to the fact that the therapeutic landscape has changed significantly with the development of new molecular therapies, and evidence that early commencement of therapies such as steroids and physiotherapy improve outcomes. Furthermore, many countries see that diagnostic odyssey is a significant factor and have changed their screening protocol to include this in their screening criteria. The previous screening programs for Duchenne utilised a single-tier protocol similar to the one that I've just described here for the Wales screening programme, whereby those boys with a raised blood spot CK activity would be followed up at 6 to 8 weeks of life to undergo further testing to confirm or refute that original finding on the blood spot card. However, such a protocol causes significant harms, and in addition, the time delay no longer fits in with many healthcare infrastructures around the world. In the last couple of years, with the recent advancement of molecular technologies, Jerry Mendel and colleagues in Ohio recently developed a two-tiered screening protocol for Duchenne. And this was developed in order to reduce the false positive rate that is observed in the previous screening programs. And the approach that Jerry coined was based upon the fact that those samples with an increased CK activity were then analysed to detect DMD gene deletions and mutations using DNA extracted from the original screening sample. And this protocol is very similar to the cystic fibrosis screening protocol that is utilised in many countries around the world. Whilst the CK enzyme test has been used for many years in a variety of different screening programs, there are, however, limitations with the use of this test. Firstly, there are issues with reagent stability, and this makes it very difficult to automate for high throughput screening. Furthermore, there is a lack of standardization with a variety of different sources of creatine kinase being used at various different temperatures. And furthermore, the stability of creatine kinase activity in blood spots is poor. Despite the fact that there have been huge investments to discover new therapies to treat this devastating condition and to discover biomarkers to assess the efficacy of these new treatments, there has not been any focus on developing a suitable high throughput screening test for Duchenne. The bloodspot CK test is based upon enzyme activity, and it measures the total CK activity. However, creatine kinase is an isoform, and a variety of different forms exist in blood. They are MM, MB and BB, but it is the CK-MM isoform that is specific to the skeletal muscle, and it's a CK-MM that is elevated or significantly elevated in these boys with Duchenne. And following our experience in Wales screening for this condition, we developed a two-site chemiluminescent based immunoassay to detect CK-MM in dry blood spots. The development of this blood spot test for Duchenne would be better if it was actually developed onto a commercial immunoassay analyzer, as this would enable robust high throughput testing using standardized reagents, thereby providing a safe and sustainable screening program. And in collaboration with PerkinElmer, this test was developed for use onto the PerkinElmer GSP analyzer using their proprietary European labelled system. Using pure forms of the various CK isoforms, the cross-reactivity to the CK-MM was excellent at 100%, although there was some slight cross-reactivity to the CK-MB form. However, the concentrations of CK-MB in the blood of boys with Duchenne are 100-fold lower than that of the CK-MM, and therefore this slight cross-reactivity at this lower level is clinically insignificant. The runtime of this assay is just under 5 hours, and that's similar to other immunoassays on the GSP analyzer. And in just under 13 hours, 26 plates, or equivalent of 2,500 samples, can be measured. And therefore, this assay has allowed high throughput screening for Duchenne for the first time. This slide shows a typical standard curve for the CK-MM assay on the GSP analyzer, and we can see an excellent working range from 10 to 8,000 nanograms per mil, with a limit of detection at around 3 nanograms per mil. There is good inter-assay precision at less than 7% across the concentration range that is comparable to other assays upon this analyzer. This slide shows a box plot of the CK-M concentrations in a series of samples from adults, newborns and older boys with Duchenne. And what we can clearly see is that the CK-MM assay can clearly distinguish the results from newborn infants from the older boys with Duchenne. We also see that in adults that we have lower CK-MM concentrations, and that's in keeping with the association that there is an inverse association between age and creatine kinase. The results and method validation has recently been published. It is now online on the clinical chemistry website. To further validate our new screening test, we undertook a population-based study, and this slide shows the data of bloodspot CK-M concentrations in nearly 9,000 newborn infant boys. And the 99.98 centile was at 700 nanograms per mil. And in this population-based study, we identified 10 cases that had CK-M concentrations greater than our cutoff at 700 nanograms per mil. And the concentrations in these 10 cases range from 703 to nearly 5,500 nanograms per mil. This table illustrates the 10 cases that we identified above our cutoff, and what we can clearly see at the top of this table is the fact that we have 3 cases, and they all have significantly elevated CK-MM concentrations in the blood spots, and they're all greater than 2,800 nanograms per mil. At follow-up, they all had significantly elevated serum CK activities, confirming the initial screening result, and the outcome is that these 3 boys had genetically confirmed Duchenne muscular dystrophy. Of the remaining 7 cases, what we can see is the fact that they all had much lower CK-MM concentrations, ranging from 1,800 down to 703, and they all had normal serum CK activities at the follow-up point, and they were deemed as not affected. However, there were 3 cases whereby the parents refused follow-up, but these 3 cases that we can see all had much lower CK-MM concentrations that were less than 1,000 nanograms per mil relative to those genetically confirmed cases that were all above 2,800 nanograms per mil. This slide shows the observed association between CK-MM concentrations and the age of the infant at sampling. Therefore, appropriate cutoffs will need to be derived based upon the age of which the screening samples are collected. And those countries whereby blood spots are collected within the first 48 hours of life would be expected to have a much higher cutoff relative to those countries that screen around day 5 to 8 of life. So in conclusion, the development of the molecular therapies has very much renewed the interest in newborn screening for Duchenne muscular dystrophy. The CK enzyme activity test is not a robust assay and should not be used as a first-line screening test. Our experience here in Wales has led to the development of this assay in partnership with PerkinElmer, and this assay has now been adapted for use on one of their mainstream analyzers that is present in many newborn screening laboratories around the world. The use of this immunoassay is part of the 2-tier screening protocol that's been devised by Jerry Mendel and colleagues in Ohio should result in a more sensitive and specific screening protocol to identify boys with Duchenne. However, it should be remembered that CK is a marker of the disease process, and therefore there is a risk of false negatives. And clinical awareness of DMD is important in order to prevent late diagnoses of boys with this condition. This slide shows the front cover of the October edition of 2009 edition of the Lancet Neurology, in which some of the results of the exon skipping drug trials were first published. And I think probably the most poignant aspect of this picture is the fact that we see an empty wheelchair and we see a young teenage boy who really, if we look at the natural history of this disease, should be in that wheelchair, but he's not. He's still standing. And I think with the advent of these new molecular therapies, there is a real future for these boys. Finally, I'd like to acknowledge the support and collaboration with the colleagues at PerkinElmer, in particular Teemu and Petra, my colleague Professor Ian Weeks in the School of Medicine here at Cardiff University, my team in the Wales Newborn Screening Laboratory, and also the team in China who undertook some of the pilot work for the DMD program using this new test. Thank you.